Good evening, everyone. Today I am going to present a case on unilateral cleft lip. Myself, Dr. Tejeswi from Kilpauk Medical College, Chennai, and my guide is Dr. Angelin Selvaraj, a professor in Kilpauk Medical College, and mentor Professor Dr. Lakshmi Ma'am, Osmania Medical College. My case, 8 months old female, a resident of Kolattur, Chennai, came with the chief complaints of split in the left side of lip since birth. History of present illness, patient was born with split in the lip in the left side. There is no history of upper respiratory tract infections and no history of ear infections or no history of any other anomalies. And developmental milestones are adequate and immunization status is up to date. Antenatal history, child is born full term with normal vaginal delivery with for a consanguineous marriage couple of second degree. She is the first child and the only child in the family, and the age of mother and father at the time of birth is 24 and 28 respectively. No history of any drug intake or no history of fever in the antenatal period, and no history of radiation exposure or no history of addictions like smoking, alcohol, etc. And no history of folic acid intake by the mother during the first trimester. And there are no similar complaints in the family, either in the parents or in the sibling, no siblings as such. Past history, as soon as the birth, the parents were counseled about the cleft lip and they were explained about the procedures and the feeding techniques. General examination. Patient is examined in a well-lit room with a proper consent from the parent. Anthropometric measurements are height being 65 cm, weight 7 kg and BMI of 16.6 kg per meter square. And Karnowski performance score is 90%, and child is adequately nourished and hydrated. Child is alert and active with no pallor, icterus, cyanosis, pedal edema, clubbing or lymphadenopathy. Vitals are within normal limits and other systemic examination are normal. Calvarium, vertebral, anorectal and limbs appear normal. This is the child. Local examination of lip. There is discontinuity of lip seen on the left side, and there is discontinuity in the white roll. Apex of cupid on the cleft side is raised, and lip height is reduced on the cleft side. There is a muzzle bulge present on the cleft side. And the nose examination, nasal sill is wide on the cleft side, and nasal floor appears wide. The columella base is slightly shifted towards the non-cleft side. Alar flare is present, and nasal septum appears to be normal. Alveolus and palate appears to be normal. Dentation didn't appear. My diagnosis is left side unilateral incomplete cleft lip with nasal deformity without any syndromic association. Group 1 cleft according to Nagpur classification.
Yes.
Yes, sir.
Yes. Sir, would you like to ask anything in history and clinical findings?
Clinical findings seem to be okay, right?
Who gave Nagpur classification?
Professor C. Balakrishna, sir.
And what were the alphabets used for that in his original paper?
Last.
Because that is relevant even today when you are having an era of computer.
Yes.
What were the alphabets used in Nagpur classification to describe cleft lip and palate?
I don't remember, sir.
When you mention Nagpur classification, you need to know that, isn't it?
Group 1, Group 1A, Group 1A.
Alphabets which used. Okay, just go through it. Go through his paper.
Yes, sir. Yes, definitely.
So what will you do now?
The first I would investigate the patient, preoperative blood investigation,
Okay.
and after hemoglobin should be more than 10 gram%, and weight is it is more than 10 pounds, that is 4.5 kgs, and I will see the total leukocyte count. It should be less than 10,000.
Okay.
And the age is now 8 months, so the other criteria rule of 10 weeks is also crossed.
Okay.
And after preoperative investigation, I would counsel the parents regarding the procedure and complications and post-operative follow-ups, and prepare the patient for operation surgery after anesthetic assessment.
How is the child being fed?
Now the child is being fed breast milk, sir. Breast milk, and the patient gave history of feeding through Paladay at the age of 2 months and 3 months. Afterwards, now she is spoon fed plus breastfed, sir.
Okay. Does it have anything to do with the repairs before surgery?
The alveolus involvement is. I didn't get your question, sir.
Okay. No. Do you change the feeding advice according the child is being still breastfed? Will you go ahead with the surgery or will you ask them to convert to anything else?
I will continue with surgery, sir, and since it's 8 months, the weaning is also has been started.
Okay.
So, and but the BMI is less than 18, which is Indian standard. It's a low BMI. So I
Okay.
will ask any nutritional supplements.
Yeah, that's what I asked, whether the child, okay, right, go ahead.
Nutritional supplements to be added, high protein diet, and any formula feed should be added apart from the breast milk.
One is sometimes, even though some surgeons say that there's not much of problem with breastfeeding after surgery, some people have this thing. So would like to always go for a spoon feeding so that the child is better taken care of. Okay.
Yes, sir.
Second, you are told that the child's weight was 7 kg. Okay. It's
Yes,
8.
sir.
Is it the weight according to the age of the child and not just you're just passing 10 pounds? Okay. You
Yes,
should
sir.
always check with the pediatrician and the growth chart whether the
Yes, sir.
weight is uh,
According to age of the child, the weight should be from 7.2 to 7.5 kgs, sir. She
okay.
is 7 kgs.
Yeah, slightly on the lower side. Okay. Does it
When you
require anything
mention
else? Yeah.
the criteria, you should not say 10 like because according to age, you have to mention. This is the reason why it's pointed out. Okay.
Yes, ma'am.
Yes.
So how will you
So,
go ahead next?
Madhukar, sir, anything you want to ask or add?
No, just on a lighter side, this is one situation where we prefer to have spoon feeding
Yes.
on a lighter side. Otherwise, we do not advise spoon feeding in proper terms. Right. Carry on,
Yes.
please.
Yes, sir. I would proceed with the Millard rotation advancement flap technique, Millard kiloplasty for this patient.
Yes.
Um, Let me proceed, sir.
Okay.
After pre-anesthetic assessment, the patient after counseling, the patient is brought onto the operation OT table, and on the OT table, the patient is in the supine position with the head slightly raised up, and general anesthesia is given with endotracheal tube placed towards the tube placed towards the lower lip, or raised tube, south facing tube can be used. Uh, After the anesthesia assessment, before the anesthesia assessment, the points, few points are marked over the lip, upper lip, on the cleft side and the non-cleft side, and are tattooed with junction violet. The markings are, the first marking is done at the cupid's elbow, which is on the, I'll show it. Marked on the cupid's elbow. Cupid's bow.
Cupid's
The
bow.
first point is placed on the cupid's bow, and the second point is placed on the immediate elevation, just on the non-cleft side. That is the second point, and the third point is placed. The measurement of 1 and 2 is measured, and equidistant. The third point is placed on the cleft side. Cleft side. It is 3, and columella base is pointed as 4, and the opposite side on the cleft side, the diminution of the white roll is pointed as 5.
Tejeswi, I will tell you a few points before proceeding to the lateral element. The points what you told, the first point is lowest point of the cupid's bow in the center. Okay.
Yes.
The
Yes,
second
ma'am.
point is the peak of the cupid's bow on the non-cleft side.
Yes, ma'am.
Okay. So the distance between the 1 and 2, you will transpose on the cleft side from point 1 and
Yes,
point it as a point 3. Okay.
yes, ma'am. Yes, ma'am.
Now you proceed.
This is point 3, and point 4 is the base of the columella. Base of the columella. And point 5 being the towards the non-cleft side, lateral to the columella, and 6 being the LR base, 7 being the edge of the lip, and the lateral edges of lip, 8 and 9, 7 and 8,
That
sorry.
is commissure on the non-cleft side.
Commissure on the non-cleft side, and 8 is the commissure on the cleft side, and 9 being the end of the white roll. The starting point of the diminution of the white roll is considered as 9.
What is the name given to that point?
Nordhoff's point.
Yes. Okay.
Nordhoff's point. The next point is the columellar base on the cleft side.
No. The
10.
Nordhoff's point, that is not
ma'am.
the only criteria.
Yes, ma'am.
What are the other 2 criteria you follow to point, you mark the point?
The first criteria is the diminution of the white roll, and the second criteria is the distance between the point, the summit point, and the
Peak of
fissure
Yes.
is equal to the 2 and 7. It should be equal to the 10 and 9. That point is taken as that the point is taken as 0.9, and the other one is the lip height, lip width, ma'am. Where the lip width is maximum, there the point is taken.
So in another terms, I'll tell what everybody understand. The fading of the white roll. Okay. Where the thinning of the vermilion starts, and the measurement from the commissure on non-cleft side, from the peak to the commissure transposed on the cleft side.
Yes.
Okay, these are the 3 criteria, you will mark the node as point. Okay.
Yes. Yes. After 9, 10th incision on the base of the columella, 10th point, 11th point on the nasal ridge. Sorry, LR base.
Yeah.
11th point.
Okay.
Now these points are with the 25 gauge needle. 25 gauge needle. We dip in junction violet and tattoo the points. Points are tattooed, and after giving a local infiltration with 1:2 lakh international units of adrenaline, along with lignocaine and bupivacaine in equal proportion, is infiltrated all over the points, and the incision is marked. The incision being the third point towards the columella base, and columella base on the non-cleft side, which is not a straight line, it's a curvy linear incision. A back cut.
Why do you infiltrate?
Sir?
Patient is under general anesthesia. Why do you infiltrate?
What is the need for the infiltration with adrenaline xylocaine when anesthesia, general anesthesia is given? That is the question.
Tumescent, it acts as the hydrodissection, and also the bleeding hemostasis can be achieved while giving incisions.
And you said that after
Are you
infiltration,
using
you mark
xylocaine or
it.
bupivacaine?
Sir?
He said bupivacaine. Are you using bupivacaine or xylocaine?
Sir, mixture of bupivacaine and xylocaine, sir.
You are not using.
You practice
mixture of-
at your institute like that?
Yes, ma'am.
You use a
should
mixture
know
of
how much
bupivacaine and
has to be
adrenaline.
you should know the drug dosage also. Okay, how much you will add and what is the concentration, how we prepare, because child you are giving. Do you know how to calculate?
Yes, ma'am. 5%
What is the use
lignocaine
of using
with
bupivacaine or xylocaine? You can use the simple adrenaline saline, which you normally we infiltrate.
yes,
What
sir.
will be the use of using bupivacaine or xylocaine?
Post-operative, the pain will be less, sir. For this
That's
car.
why you use the bupivacaine, not the xylocaine, right?
Yes, sir.
But you should know the dose. Dosage
Yes.
is very important. How much you will inject.
Yes, sir.
So you will mark after infiltration or before infiltration?
Before infiltration, sir.
You just now said after infiltration you will mark. That's why I asked.
Oh, sorry, sir.
Right. Carry on.
So the incision points are from 3.3 towards the columella base. Towards the columella base of the non-cleft side, a curvy linear incision is made, and based on the requirement of the height of the lip, we can give a back cut, or this curvy linear incision may be enough on the non-cleft side. On the cleft side, the incision is marked from the point 9, which is a node of point, towards the columella base, and it angulated towards the alar base. The non-cleft side part acts as a rotational flap, and a cleft side flap acts as a advancement flap.
So this
Tejeswi.
curvilinear incision, one curvilinear incision will make a C flap, so called.
No, sir. When the curvilinear incision is made, after that the remnant mucosa and the skin makes the C flap, sir. Which can be rotated towards the nasal sill or towards the columella, based on the requirement we need.
What is the lateral limit of this curvilinear incision? Where you should stop?
The curvilinear incision should be stopped the columella base, the starting of the base, columella base.
Columella base is a wide area, no?
Yes, sir.
So you must know where you cannot proceed further, that curvilinear incision.
So the Cupid's bow, the horizontal and the vertical line drawn in the Cupid's bow, sir, should not extend
No,
beyond.
it's a midpoint. Okay. There are two bases, columella base on the cleft side, non-cleft side. It's the center point.
Center.
It should not cross the center point.
Yes.
Okay.
Yes, ma'am.
You call it rotation and advancement flap. What are you rotating?
We are rotating the non-cleft, the philtrum filter, the Cupid bow and the filtral ridges from the non-cleft side towards the cleft side. That is the flap on the non-cleft side acts as a rotational flap.
No, part of it is correct. You mentioned Cupid's bow. Then only you'll know when to stop your rotation, whether you go for a back cut or not. What you're rotating is the Cupid's bow. Okay.
Cupid's, yes.
It is to come to the transverse position. Okay.
Yes, sir.
That's when you can.
What is your aim of this rotation?
To maintain the Cupid bow.
To bring back the peak of the Cupid's bow on the cleft side is raised up. Okay.
Yes,
so you should bring it down in symmetry to the peak of the non-cleft side Cupid's bow. So
yes,
that is your aim. So how do you know how much it has to be bring down and how much the back cut has to be given?
The measurement from the highest point to the Cupid, the measurement of the bilateral side is made, and the difference of the measurement is the back cut given, ma'am. The extra thing required towards to rotate the flap. Rotate the flap into the normal position, into the center, to bring back the Cupid's bow into the central position. The extra thing is the back cut should be given.
Yes, whenever the transverse position is achieved, then it's okay, right?
Yes,
you'll have to
yes, sir.
Fill up the defect with this thing. Both this and the triangular flap method achieve the same thing. Okay?
Yes, sir.
Right? Miller's does it at a higher level. Just under the nose, you are creating the defect and advancing the flap through that. Okay?
Yes,
on the other hand, triangular flap does it at a lower level. That peak itself, we cut it, and that area is filled with this thing. So ultimate aim is to get the Cupid's bow into the transverse position. Okay?
Yes, sir.
Dr. Tejeswi,
yes, sir.
You are doing the millards. What is millard 1 and millard 2?
Millard
1, millard 2. Regarding the usage of C flap, no?
Yes, sir.
I have now C flap.
When the C flap is, when C flap is excised, it is millard 1, sir. And C flap is used for the reconstruction of the sill or columella is 2.
C flap is never
excised. We never excise.
Never excise.
It can be used to lengthen the columella on the cleft side or reconstruct the sill of nostril sill. Okay.
Yes, ma'am.
Millard used to recognize the nostrils in Millard 1, which is called the Millard 1, which he described first. He used to recognize the cell with that C flap.
Yes, ma'am.
But later on, he found that there is quite a real deficiency is in the hemicolumella. Half of the columella, which is on the non-cleft side, is good size.
Yes,
But
ma'am.
hemicolumella on the cleft side, there is a deficiency.
Yes, ma'am.
So he utilized that C flap for that, right?
Yes, sir.
So to lengthen
And
the columella on the left side.
in that way, he also gave the right position to the columella as well. Otherwise,
Yes,
there was a drop on the left side columella used to be there in the Millard 1.
yes, sir.
Now, my simple question is, why will you do Millard? Why not other repair? Why you are doing Millard? It's a very common question asked to every student in the exams. Why are you doing Randall Tennyson? Why are you doing Millard? Why are you doing Moeller? Whatever repair you are doing. Why
Yes, sir.
you have chosen Millard for yourself?
So one thing, sir, Millard is the commonly done procedure in our hospital, and the second one, the geometry, less amount of geometry is involved in the Millard rotation.
Actually, I will
Is
reply
it
it
the
like that.
advantage
The
or the
procedure which you are
disadvantage?
comfortable with.
Disadvantage.
Actually, what you have learned the most, whatever your unit is doing the most, you will be comfortable with that
Yes, sir.
as a young surgeon.
Yes,
Then
sir.
later on, you can choose anyone. But what at the outset of your career, whatever is being followed in your unit, what you are commonly doing, you will be very comfortable with that.
Yes, sir.
And maybe at your unit, you are mostly doing the Millard, so you will go for the Millard. But there
Yes,
may
sir.
be other indications where you Millard cannot be done, may not be feasible. We'll leave that.
Yes, sir.
You are comfortable with it because most commonly you are doing in your unit that you have seen your teachers doing it. You are also doing it. That should be the reply,
Yes, sir.
right?
Yes. Yes, sir. Thank you, sir.
What are the advantages of Millard over the Tennyson Randalls? Though it is done routinely in your unit, but
Yes.
you should know what are the
Yes.
advantages of doing the Millard and which cases are most favorable cases.
Yes, ma'am. Scar is in the filtral ridge, ma'am.
Yes.
Scar in filtral ridge. Next, there is a creation of the symmetrical Cupid's bow,
Yes.
and the placement of tissues in the normal positions can be obtained through Millard. And when the rotation and advancement flap is done, there is a simultaneous nasal reconstruction can be achieved, ma'am. And preservation of the filtral dimple in the center.
Yes.
And that's all.
Which type of lips it is difficult to repair with Millard?
4 mm. When the height difference is more than 4 mm, the lip from the from point 3 to point 5, the height between compared to both sides is more than 4 mm, then Tennyson Randall repair is preferred.
Is that the only that is actually called the difference of between this length? It is a drop. Okay.
Drop, ma'am.
Yeah. Drop it is called. Okay.
Yes.
So is it the width or the length difference only?
Width also, ma'am. 5 centimeter. I'm not sure, ma'am. 5 centimeter.
Measurements are not given there. Actually, it is said that wide cleft.
Wide cleft.
Wide cleft.
When the wide cleft, when the drop need is more, wide cleft, they are regarded as not good for the
Yes.
Millard
Yes,
system.
yes, sir.
And most favorable are microform lips and incomplete lips. Okay.
Yes, ma'am.
Now there are many modifications of the Milad. You know of some modifications what have been done, what people are doing presently, are they are not doing the real Milad, what they call it Milad, but they are doing the modifications actually. Na?
Molar,
Can you name
molar is the
modification?
modification, sir.
More or less modification. What is
Molar,
that?
where the incision, the first incision up to the non-cleft side columnar towards the columnar side, the incision is extended towards the nasal cell such that the incision line, the filtral ridges appears separate, the cosmetically good.
Actually, there is a break in the upper part. So more of the lateral element, lateral triangle, which is advanced, has to go into the defect which you have created there.
Yes,
But
sir.
what is Moeller doing there to
The
decrease this a bit? He
back
is going incision wide. Actually, Millard is going at the lower end of the columella. A
yes, sir.
curvilinear incision, then giving a back cut, just stopping at the
Midpoint,
midline.
midline.
Midline, yeah, before. But Moeller is going into the
Nas
columella.
columella. Yes, sir.
Columella.
Columella. Yes, sir.
He gives the incision in the columella. Then the C flap created, he repairs with the C hemicolumella repairs with that. And so there is not much of the advancement of the lateral element.
Yes, sir.
It also depends upon how much drop you need, right?
Yes, sir.
But lateral element is not much. Basically, when Millard was, they used to give what is called as Eller incisions also used to be given, right?
Yes,
To
yes, sir.
get that triangular flap more medially. But today, in today's world, almost there it has gone out of vogue now. We don't need them actually,
Yes, sir.
right? Any other thing which has been added to this?
Uh,
Many people are now doing what they are not actually use this
tissue.
triangular flap. They are incision they used to give in the proper lip. Now what people are doing, they are doing just 1 or 2 mm above, so that the rim of that triangle it doesn't show off. It just goes toward the sill of the nasal sill. You
Yes,
got my
sir.
point? So that it is camouflage there,
And get you, sir.
right? Pardon? It is
I
one of the modifications.
yes, sir.
Going
Yes.
a little bit 2 mm above the proper lip
Proper
for
flip.
the triangular incision upper triangle,
Yes, sir.
right? Actually, there is what is said that in a lip there is actually a deficiency. You have a deficiency on this side, right?
Yes,
So
sir.
you have to fill this deficiency with some tissue which you are getting from this. What
Yes.
Millard has found that the deficiency actually is in the upper part of the lip.
Yes,
He
sir.
he admitted that the deficiency is the upper part. That is why to make up that deficiency, he is getting the tissue from upper part lateral side.
Yes, sir.
That's why there has been the division that the some people are using the if triangles they get they use the triangle in the upper part of the lip, in the lower part of the lid, some use the middle part of the lip. So
Yes, sir.
tissue is to be given. It is said only one place is there where there is no deficiency of the tissue in the cleft side. What is that? All all parts of the cleft are deficient in the tissue, right? Which part
Yes.
there is surplus tissue not deficient? Why?
The fibrous.
What madam told you, node of point. If you see,
Not.
node of point has surplus tissue there. If you go
Yes.
by vermilion only, you see that there is a fullest vermilion there.
Yes, sir.
That's the madam told you that whenever there is the fullest and it starts decreasing, it is your node of point.
Not of point. Yes, sir.
Other features are there. Fading is there. You have to mark from the commission. But this fullest is the very important point. So it
Yes,
is said this is the only tissue on the cleft side which has surplus tissue. Otherwise, along the whole of the cleft side, you will see there is deficiency of the tissue, right?
yes, sir.
And you have to know the proper classification. There are many classifications of the cleft lips. You have to
Yes.
know them all for the examination. Whatever you are using it, that is different.
Yes, sir.
You have to know the classifications, and you have to know, you have to master one procedure, but you have to know other procedures also.
Yes, sir.
Will you do the muscle repair also?
Sir, the first, the after giving incision, the muscle repair, the orbicularis oculi repair is done first, sir.
This.
Is
Oculus
approximated.
oris.
Orbicularis
Oris.
oris, sorry, sir.
How
Where
will
will
you
Orbicularis.
you
dissect the?
find and what will you
How will
do
you
to
find
this
the
muscle?
muscle? How will you dissect the muscle?
Where do you find the muscle attachment?
The muscle attachments towards the cleft border of the clefts, and also the piriform fossa of the maxilla.
No, no. They will go to piriform fossa or something specific there. Piriform fossa is a large, I think it is a big area, no? Where
It
does the
is a
muscle go?
yes.
Yes,
Where they are attached mainly. You have to detach those things.
yes, ma'am.
Medial side, lateral side, where they are attached.
Medial side, ma'am.
Medial where? There are two elements, isn't it? There is discontinuity. So each medial bundle where it attaches and lateral bundle where it attaches.
Medial bundle towards the alar, near the alar base, ma'am. Piriform
Medial
medial, ma'am.
medial bundle towards columella, base of the columella.
Columella.
Is it
Minus process there, right?
that?
Yes,
As
ma'am.
Nasal
madam said rightly, nasal spine, which is called, right?
Nasal spine, sir.
nasal spine.
Yeah.
Yes, nasal spine.
And
And
lateral
there
is
are,
at the base of the columella and there piriform.
Yes,
and you have to suture, you have to repair the muscle very well. As rightly Dr. Bhattacharya sir said, muscle is the main element in the repair.
yes, sir.
And as he was saying, always whenever you see there is some difficulty or there is some in the lip post operatively, everybody has an intention that I will go to the skin and correct it. But most of the time, rightly pointed out by sir, that it is a failure. You cannot correct with the skin, maybe by
Yes.
some diamond excision or like that.
Yes, sir.
For that, you have to do the proper revision. You have to go to the muscle. That is
Yes,
very important point, sir raised it because of his experience. He has a really, really long experience.
yes,
That's
sir.
why muscle repair is of paramount importance, especially in unilateral cleft. And you have to repair the muscles at all the levels.
Yes,
If you go by the book also, you have the levels of the muscles. You have to repair the muscle at the upper part of the lip, at the middle part, and lower, because
lower.
orbicularis oris has actually different parts. If you go right,
Yes,
you have to repair them separately, and actually your repair is held by this only.
yes,
I have some people are even using for the skin. They are not removed. They are using the 80 ethylene, which they don't use. No need to remove that sutures. What is important is that your muscle should be strong enough to hold the repair.
yes, sir.
For the skin, you can use anything, right?
We
Many
use,
centers, some center use very thin suture for the lip.
yes, sir.
For such a skin that you 80 we use for anastomosis, microanastomosis, the microvascular.
Yes, sir.
So it goes of its own. There is no need to remove the suture.
Yes, sir.
That is the importance. I don't want to say that we can use 80. We are using 80 here. I want to highlight here the importance of muscle. Muscle repair is of paramount importance. Muscle
Yes,
should
sir.
be nicely dissected, and there are principles. How much millimeters you have to go on the lateral side, how much you have to go on the middle side, and you have to just hold that bunch and suture together.
Yes, sir.
Get a good,
Good
robust
set,
repair.
proper.
Right. Dr. Bhattacharya sir will bear me out. Sir is there?
Yes. No, actually, yes, yes. Actually, the candidate must know only answer of one question, which will encompass everything, and that is
Right.
that what is the difference in the muscular anatomy of the cleft as compared to the normal limb, the
Yes.
orbicularis oris muscle. What is the difference in the cleft cases as compared to normal? If you know this, if you have this idea, you can answer all the questions. You can do good repair. So basic is that. Can you
Yes, sir.
describe it?
Yes, sir.
What is the difference?
Normal lip has a crisscross connection is connected. The one side, the left side orbicularis oculi is inserted to the filtral ridge.
First, you should mention about the types of fibers of the orbicularis oris.
It's a circular fibers and
Then you will know the insertion and
yes,
the continuity. Abnormal insertion and continuity. First, you must mention about the types of fibers of orbicularis oris.
yes. The
If
circular,
you,
sir,
if you know you answer that, then it will be better.
sir, the
Because
cruciate fibers.
the description of these fibers are related to the function of a normal limb.
It's a power.
Therefore, you must know the clear understanding of the normal orbicularis oris. Then you go to the abnormal.
Yes, sir. Orbicularis oris is a circular muscle fibers, sir, which crosses the filtral groove and inserts into the opposite filtral ridge, which forms a crisscross fibers in the filtral groove.
I don't think this is the full answer.
Actually, sir means to say, sir, maybe he is not actually getting the question. There are different fibers. Maybe there are fibers in the upper lip. They have a function, middle part, lower part. Sir, you mean to say that only? There are different fibers in the orbicular and they have proper names, right?
Yes, sir.
It is a single muscle. It is a muscle, but has parts. Sir means to say that. Sir, वही पूछ रहे हैं. Sir, ask actually that. That's why that is why we are not going a single repair. We are trying to repair them at 2-3 places, as you have must have seen your
Yes.
mentors doing. Sir, I think sir is asking that. वही सर पूछ रहे हैं आप?
हाँ जी, हाँ जी.
सर वही पूछ रहे हैं.
This normal
There
anatomy
are
is
fibers
well
along
described.
the vermilion. There are the fibers. Yes.
So you
Sir,
must
वही
know
पूछ.
the normal anatomy of the muscle. Then you will enjoy the surgery. You will know what you are doing.
Yes, sir. Yes, sir.
What will be the effect of a particular repair, muscle repair, and so on.
Yes, sir.
So you must know that basic.
I will know, sir.
Similarly, the vascular anatomy. What happens normally and what happens in cleft. The vessel, how does it differ in cleft? Both in bilateral, unilateral. These are very interesting areas. And if
Yes.
you know this, then you will enjoy the surgery more. And the results will be better.
Yes, sir.
And one thing I will add here, sir, he will be asked in the exam to mark the markings for the right sided lip. Because left side you are doing on and off, right?
Yes, sir.
Tejeswi?
Yes, sir.
You
Yes.
must be doing the left side lip, but you should also master marking the right side. Am I right, sir?
Yes, sir.
Because I was asked the same, matlab so long back, I was asked, because examiner always asks you to mark the right side, right?
Yes,
On the
sir.
paper, you should practice marking for the right side cleft, right?
Sure,
Left
sir.
side you are very frequently doing and you are very easily doing.
Yes.
But right side you commit some mistake here and there.
Yes,
So
sir.
you have to master. It is for the exam point of view, not here. I am just
Yes, sir.
telling you should do marking for the right side also, because
Right side.
left side we see very commonly, right?
Yes, sir.
And very pre-operative, you have to prepare the patient. That Bharathi sir and sir Bhattacharya sir rightly said, immunization is very important. You have to advise the patient, attendants, and or the parents
Yes.
about the immunization status. They have not skipped those things.
Yes.
Proper nutrition, weight gain chart should be properly made there, whether the
Yes.
child is gaining the weight, because these patients present to you at the birth. They will go maximum, they come to you after 4 or 5 days or
Yes.
immediately after the birth.
Yes, sir.
So parental counseling is very important in such cases.
Yes, sir.
So they have to treat this child as a normal child as other children are there. There is nothing specific.
Yes, sir.
But only you can advise them only edit thing he might need a surgery. Rest you have to continue with the same nutrition wise,
Yes.
immunization wise. Because I
Yes.
have seen many people if they come late, they have not immunized even the child. So
Yes.
immunization status is very important.
Yes, sir.
And weight gain. You have to see whether child is gaining the weight, he
Gaining
is
weight.
being properly nourished. Yeah,
Yes.
properly nourished, that is important. And nowadays, what criteria previously we had that 10,
Sir.
it no longer holds. But if it is there, that is better thing.
Yes, sir.
So why do you call it cut as you go method? Millard.
Uh, we have to proceed with the incision after giving a skin incision. We have to proceed the incision as we proceed towards the muscle.
Cut as you go. Sir, वही पूछ रहे हैं.
When you are going to, after making the skin incision, you're making a full thickness flap, okay?
Yes.
Only when the incision goes to the full thickness, you will get a drop, okay?
Yes.
Right. So once this thing, sometimes you can stop with just at the base of the columella itself. Sometimes you need to get a back cut. So always check how much of drop you have given, okay?
Yes. Yes.
Similarly, whatever lateral point you have marked, lateral point also, sometimes always the commissure to the normal Cupid's peak may not match the commissure to the
Yes.
point you have marked, no, those point, okay?
Yes, sir.
So whenever there is a discrepancy, always if the say white roll disappears slightly medially also, okay?
Yes, sir.
Always go to the point where the bulk is the maximum and
Yes.
the vermilion starts to taper.
Yes.
So if you go on that side, then you will always be safe. So even after suturing this, what is a $1 million suture?
$1 million suture is a after suturing the muscle, the vermilion borders, the vermilion suture approximating the white roll.
Yeah, white roll. Will you put it at the white roll or anything
Just
different?
1 centimeter above the white roll.
1 centimeter.
1
Sorry,
millimeter.
1 mm.
Yeah.
Sorry.
Just just above and just below one.
Just
okay.
below.
Then you suture it. Then you will not be scarring the white roll. Okay.
Yes.
Then the continuity will be better. In that case, you notice that still it's not achieved a drop. So what you can do? That's why all this cut as you go method came.
Back cut can be.
No, you already sutured. Back cut is for the medial side.
Yes. Triangular flap and
Lateral side, you can slightly move. Medial side drop is adequate. Lateral side, if you think that length, whatever is there, it's not sufficient, then what you can do is whatever point you have marked, the white roll, you can move it a bit laterally, 1 more millimeter.
1 more
Okay.
Yes.
So that will achieve the height. That's why this cut as you go comes in. Okay.
Yes.
Whatever is in the width part of it, you make it converted to the height part. Okay.
Yes. Yes.
Anything
That is
else?
a very, very important point Ravindra sir has raised. Right?
Yes.
It is that now, if you go by present scenario, one cleft surgeon is Fisher. Right?
Fisher, sir.
He advises always if you mark your node off point, right?
Yes.
At the, you go just 1 mm lateral to that point. He routinely do this.
Yes, sir.
I remember this from sir. He advised that you should go 1 mm lateral to the node off point to have the adequate length of the lip length, adequate lip height, I can say.
Yes.
Right?
So what are the things which will pull it back again? So what do you do to prevent the scar contracture? Anything else you'll do? Any other things you'll incorporate?
Scar intraoperatively, sir.
Intraoperatively also you can do it. The small Z-plasty just above the.
Small Z-plasty.
Yeah. Okay.
Yes, sir.
And one in the vermilion, so that contracture is also taken off.
Yes.
At least
Yes.
two this side. Okay.
Yes.
Right. What materials you use for muscle repair? What suture material you use for skin repair?
Muscle repair, we use 40 Vicryl, sir. And the skin repair, we use 60 proline, 60 and 70 proline.
Okay.
And for the mucosal repair, the same 40 Vicryl is used, sir.
Okay. When do you have put in a proline suture? When do you remove it?
After 5 to 6 days, sir. After
Okay.
5 to 6 days, the suture is removed, sir.
Okay. After suture removal, what will you advise the patient or the parents, child's parents?
After suture removal, a slight scar massage is advised, and routine breastfeeding and these to be continued.
Okay. You always advise breastfeeding immediately?
Immediately within first.
Immediate post-operative period?
Yes, sir.
Okay.
Will you do a primary nasal repair correction?
In this patient, the nasal the alar flare is not much in this, sir. I would not.
This picture does not allow you to comment on that actually. Okay, so if you take a walk's view, then you can have a better understanding.
Yes.
There is hardly any cleft, unilateral or bilateral, where the nasal deformity will not be associated because of the embryogenesis.
Yes.
Okay. So if you know that, it will never accept that noses are normal. And there's a lot of things can be done here,
yes,
which requires to be done. I'm asking you whether you will do at the time of lip repair, you will try to do something, or you will just leave it and do a secondary repair.
Mecon suture can be done, sir, to raise the alar.
See, it is the alar cartilage or the cartilaginous segment of the nose,
yes,
which is at fault.
Yes.
So, don't mention the stitch, rather mention on the maneuver of the cartilaginous segment. Will you do some maneuver?
Molding.
Will you try to dissect, say, submucosally the cartilage or above also? Because your incision is already there here. So you can always,
open.
line strip scissor, you can correct. I mean, what is done in your institute? Any correction?
The alar cinch is done, sir. The correct manual, I'm not able to recollect, sir.
Because when you do a Millard repair, some amount of alar base moves medially, that's okay. Let's give little fullness, but that does not correct this deformity here. And if you can do something here at this stage, because already patient under anesthesia, you have an incision here and all that. So you can have full advantage of correction. This patient may require a secondary correction later. That's a different issue.
Yes.
But initial result will be much better.
C-flap for columnar lengthening, sir.
Sir is asking about what is the primary rhinoplasty you do?
Primary
what will you do? What you will correct in primary rhinoplasty?
Are you doing in your unit primary rhinoplasty or not?
No, sir.
And you must not be knowing, maybe.
Okay. Modern day cleft
Primary
lip
open,
repair.
closed and
With
semi-open.
correcting the
Three
lower
types.
lateral cartilages.
3 types of primary this rhinoplasty, but open, closed, and the semi-open,
No,
semi-closed.
sir is asking,
Hello.
you try, sir, say you try to dissect out the alar cartilage there, lower lateral cartilage,
Lower lateral cartilage.
right? There is actually there is no, it is a misnomer. There is no alar cartilage. It is one more thing I want to add here.
Ala
Tejasvi,
word of
right?
cartilage.
There is no name like that if you
Yes.
go to book, right?
Yes.
But we name it like that, doesn't matter. So you try to dissect the cartilage, disengage them,
Yes.
right? They are obtuse actually. They are obtuse. They are not at acute angle. That
Yes.
means to say that. So you dissect them out, and by your suturing and by giving you can give Macomber whatever suture you can give. So you try to correct that flare of the ala,
Yes, sir.
right? By dissecting them from both sides.
Yes.
That is the primary rhinoplasty, and
Yes.
it has been it has a very good result. And maybe something more may need to be done as a secondary part later on. And I have seen many people, they don't need even secondary procedure later
Yes.
on follow. Why sir pushed it? Sir was asking about that. And it is a very important point sir has raised. And it is
Yes.
being routinely done nowadays.
Yes.
Primary rhinoplasty, and in this case it's not applicable. And in this thing, any lip with complete cleft lip with palate, primary rhinoplasty and an anterior palate repair are the integral part of a primary cleft lip repair, modern day. Okay.
Yes.
Always we make sure that the anterior palate is also dealt with, and the rhinoplasty is also done. What we basically do is the soft tissue is dissected out on the superficial thing, and once the cartilages are brought in together, the soft tissue redrapes over them. Okay.
Yes.
So always like the dogma, previously we were thinking that skin makes the columella. No, that cartilage, once you position it, the columella is also position is also better, and the
Yes.
slump, nasal slump also comes down. Okay.
Yes. Sir.
So previous what is that was called the skin paradigm. Skin paradigm has now shifted to the cartilaginous paradigm, right?
Yes. Sir.
Yes. That is what Sir Bharti sir was telling me.
Yes. Sir.
You are doing anterior palate repair there. The
No,
lip
sir. I am not see, sir.
many centers are not doing, but it is always advisable to do the anterior palate because it is very difficult to do it later. Almost I can see there remains a fistula always there if you don't do it primarily. You may try so hard later on, but you cannot do it at the time of palate, at a
Yes, sir.
proper palate.
Yes.
So it is always advisable to go for the anterior palatal repair at the time of lip repair when it is the complete cleft, right?
Yes. Sir.
Second thing, sir raised he was telling you that cut as you go. It holds with the millard only, right?
Yes, sir.
Whatever marks you have, mathematical marks you have made for the Randall tension, you have marked your incision, you cannot go back,
Yes,
right?
sir.
You have made your incisions, those are there,
Yes, sir.
right? You have to go through them. You cannot go back, you cannot revert back. But advantage with the Millard is that only that you have given the curvilinear incision. If drop is sufficient, you can stop there. If not sufficient, you can give the back gut.
Yes, sir.
And even people are going now across the midline also if the need arises.
Yes, sir.
Classical teaching is that you should not cross the midline, right?
Yes, sir.
But people are going across the midline so that the whole of this drops down to the what is called the transverse level equivalent on the both sides.
Yes, sir.
But you have to tell in the exam the class things. You have not to tell him that we can go, some people are going beyond the midline.
Yes. Yes.
right? You
Yes,
have
sir.
to set that we have to stop just at the midline. Remember these things.
Yes, sir. Definitely, sir.
Proper book teaching is you have to tell that. You have not to go to other things.
Yes, sir.
If you're crossing the midline
That-
also, you should make sure that you just don't go and cut the opposite filter column, because it will
That is
lengthen.
yeah,
That's
that is
one
Yes,
thing
sir.
you have to be very careful. Okay, if you
Yes,
go
sir.
and cut it, that length increases more. Okay, already you are struggling with the length on this side,
Length
lip
on
height
this.
on the cleft side. Once you
Short.
lengthen it, it gives an abnormal appearance, and you will
Yes.
not be able to match it. Right?
Yes, sir.
and this thing we are not starting here. No, we are not giving the breastfeeding immediately.
Yes, sir.
Bharati sir, you are giving immediate
No,
breastfeeding
no,
at
no.
your unit.
We also hold on.
We are
We
first.
also hold on.
Even
Hold
for
on.
7 days, 1 week we hold on. 5 to 7 days we hold on.
Sir.
We give only the spoon feeding. What Bhattacharya sir was saying, we give only that. We don't give the immediate breastfeeding.
Mm.
But
And
books are saying that you can. It is you are right. Books are saying you can start breastfeeding, but we are
Yes.
not. We are not brave enough to start. We are withholding it for some time. We are withholding.
Most of the centers, the breastfeeding is not given, sir. Only the spoon
Yes,
feeding. And
yes, ma'am.
definitely 1 week to 10 days, we will not allow them to do the breastfeeding.
Ma'am, clearly saying that book says you can immediately start breastfeeding. So the confusion goes in the student's mind also, na?
yes.
That's
And
why I was telling in our unit we are not doing. You can say in
Yes,
the exam that can be given, but our unit is not
Yes.
proposing that. We are giving like this. There is
Yes.
no harm in that. There is
Yes.
no harm. You have done very well, very
yes.
well. There were so many people to ask, and there was only one person to reply. That's a good thing. But you did very well. Very well.
Thank you, sir.
Yes. Shall we Dr. Angeline, Madam,
Yeah,
welcome.
madam.
She is a teacher of Dr. Tejaswi.
Good evening, ma'am. Good evening.
Madam, good evening.
Good evening. Madam,
Good
thanks
evening.
for giving the opportunity. Actually, I wanted you to thank because these PGs have not even started doing any of the lifts. We hardly get 1 or 2 cases in a year. They are sent to Ramachandra Medical College where the smile train is, and he is yet to go for the training program in Ramachandra. But just by observing our classes and this thing, he has the senior presentations and this he has done. He has not assisted one, I think.
Very well.
Yes,
Uh,
ma'am.
But he has done
so
very well.
I
We are
think
very
from
happy.
practical point of view, he was fumbling because of that. I
No,
should
no, no.
apologize for
He has
that.
made you proud,
No,
ma'am. He
not
has
at
made you
all,
proud.
madam.
He has done very well. He has done very
The
well.
initiation, active participation shows the guidance by you, madam.
Thank you, madam. Thank you.
Yes.
Right.
Uh, Thank you, madam. Thank you, sir.
Thanks a lot.
Great.
Tejaswi, you have presented well and answered up to mark.
Thank
We are discussing all these points so that it will be useful for postgraduates in answering the questions in exams.
Yes, ma'am.
The very nice interactive session went on today with the contribution of Dr. Ravindra Bharati sir, Dr. Bhattacharya sir, and Dr. Farooq. Very nice session. I thank all the seniors. I have seen SP Madras sir and many more seniors join. Dr. Malti Gupta ma'am in the attendees. I thank each and everyone for this contribution. Thank you, sir. Thank you all. We'll join in the next session.
Ravindra sir also, the presentation was very nice. I
Yeah,
learned a
Dr. Tej.
new points. Yeah, it was very good presentation. Very good. Very good presentation. A lot of learning for at least me. I learned a lot from the presentation. Very good.
Thank you,
It was
sir.
excellent.
thank you.
And good luck,
Bye.
Tejaswi. You did very well.
Thank
Good
you,
luck
sir.
for your future.
Thank you, sir.
Thank you.
Shall we end the session, sir?
Yeah.
Bye.
Yeah. Thank you.
Thank you, madam.
Bye to all.
Thank you all.
Have a nice
Bye.
weekend to all. Nice weekend to all.
Nice weekend to all.
Yeah.